Name is Kailash. My topic is about odontogenic kerato-cyst. Definition: Odontogenic kerato-cysts are developmental cysts that arise from remnants of dental epithelium. They are characterized by their unique lining of stratified squamous epithelium that is typically thin and parakeratinized. Epidemiology: Odontogenic keratocysts account for approximately 10% of all jaw cysts. They most commonly occur in the second to fifth decades of life, with a slight male predominance. Etiology: the exact cause of OKC is not fully understood, but genetic factors, particularly mutations in the PTCH1 gene, plays a significant role in some cases. Other factors such as trauma, inflammation, and developmental anomalies may also contribute. Clinical features: OKC is often present as asymptomatic lesions detected incidentally on radiographs during routine dental examinations. However, they can grow large enough to cause swelling, displacement of adjacent teeth, and occasional pain or discomfort. Diagnosis typically involves clinical evaluations and imaging studies such as panoramic radiographs or cone beam computed tomography. Histopathological examination of biopsy specimens confirms the diagnosis based on the characteristic thin parakeratinized epithelial lining. Treatment: management options range from conservative approaches like enucleation with curettage to more aggressive techniques such as mospirillation or resection, depending on the size, location, and recurrence history of the cyst. Prognosis: recurrence rates for OKCs are higher compared to other types of jaw cysts, particularly when not adequately treated or in cases associated with novoidal basal cell carcinoma syndrome. Case studies: a 35-year-old male patient with a painless swelling in the posterior mandible that was noticed incidentally during a routine dental checkup. Radiographic examination reveals a well-defined unilocular radiolucency with smooth and scalloped margins extending from the mandibular first molar to the mandibular angle. Biopsy confirms the presence of a thin parakeratinized epithelial lining characteristic of an OKC. Recent advances: genetic insights and identification of PTCH1 gene mutation linked to novoid basal cell carcinoma syndrome, aiding in early diagnosis and management. Improve imaging: enhanced use of cone beam computed tomography for precise assessment of OKC characteristics, aiding in treatment planning. Biological markers: research into epithelial proliferation rates, cellular markers to predict recurrence risk, and trial treatment strategies. Surgical techniques: advances in surgical approaches to reduce recurrence rates. Alternative therapy: exploration of intralesional medication and photodynamic therapy such as adjuncts to surgical treatment. Regenerative medicine: potential applications of regenerative techniques to enhance bone healing post-operatively. Long-term management: development of standardized follow-up protocols based on improved understanding of recurrence patterns. Conclusion: in conclusion, OKCs present a complex challenge in dental and maxillofacial practice, characterized by their unique histopathological features and variable clinical behavior. Advances in genetic understanding, imaging technology, and treatment strategies have significantly improved our ability to diagnose, manage, and protect outcomes for patients affected by OKCs. OKCs pose a clinical challenge due to their unique characteristic and potential for recurrence. Recent advances in genetics, imaging, and treatment strategies have improved diagnosis and management outcomes. Continued research aims to refine surgical techniques and enhance long-term monitoring protocols, ensuring better patient care and outcomes in the future.